everyone. Hi everyone. We're excited to welcome you to our video question and answer with Dr. Bautrant here at Overcoming Pudendal Neuralgia Foundation. Dr. Bautrant is an MD and a PhD and a urogynecologist that is world-renowned for his surgical expertise in chronic pelvic pain, specifically with pudendal neuralgia and perennial nerve pathologies. And he began his clinical work in pudendal neuralgia surgery in 1994. Many of his patients come from all over the world. He is a frequent speaker at many international conferences each year with the International Pelvic Pain Society and is president of the Convergences Pelvic Perennial Pain, also known as Convergences PP, a European scientific society dedicated to chronic pelvic pain research. He operates on patients at his Axiom Clinic in Aix-en-Provence, France, as well as St. Joseph's Hospital in Paris, France. And he has operated on all genders over the last 25 years. We are very excited that he has taken time today to speak with us. We know members have been very excited for this and submitted many questions, all which we couldn't get to, but he's kindly agreed to answer as many as he can. We have this list here that we will be working off of. And so we're very excited to have him. Thank you, Dr. Bautrant. He's also agreed to serve as our physician board director of here at Overcoming Pudendal Neuralgia Foundation, of which Lindsay and I are part of, and I founded. And so, Dr. Bautrant, thank you so much. Is there anything else about your background that you want to tell us that I may have missed that you want to add on?
I think you did a very elogious presentation, and thank you for that, Veronica. No, nothing more. I think we should move quickly to the main question, because that's more interesting. Regarding to my background, you explained that I work on that topic since more than 20 years now. It's a long time, and that's why I slowly get some expertise on different aspects. I began, that's true, with my work on pudendal nerve surgery and anatomical approaches. I was sure that was a very important aspect. I was right and wrong, because why? Because it was very important to find a good approach to liberate the nerve when it was a good indication. And I found that sometimes it didn't work because the things were very complicated. And then I got some expertise on the other reason of chronic pain, and slowly I got other interest in other field, like as you tell, provoked vestibulodynia, myofascial syndromes, bladder pain syndromes, endometriosis pain, and many other major aspects of this large disease, which is chronic pelvic pain. So now I think it's Lindsay's turn to begin with the
sure. Yeah, we'll get right into the questions. Yes. So the first questions we have are regarding pudendal neuralgia diagnostics. So the first question for you, Dr. Bautrant, is a two-part question. So how do you make the diagnosis of pudendal neuralgia? And then how do you differentiate between pudendal nerve entrapment, or PNE, and pudendal neuralgia, especially when pudendal neuralgia is associated with hypertonic pelvic floor muscles?
Yes, pudendal neuralgia is a big word. Usually everybody knows about pudendal nerve entrapment, which is only a part of the problem. Making diagnostic of pudendal neuralgia is quite simple. We need only two clinical aspects. The first one is the type of the pain, which normally a special neuropathic pain. The neuropathic pain is very different than the other pain, or muscle pain are really different. So this is the first aspect. We have to the description of the patient should be a neuropathic pain with burning, tingling. You know about that, unfortunately, it's very severe pain. And the other aspect is the localization of the pain, which should be in the territory of the three terminal branches of the nerve. which is around for female clitoris, vulva area, and the anus. And for men, it's also anus, of course, but scrotum and the penis. This is the area. When we are outside of this area, it cannot be the pudendal neuralgia. But so that is enough to make the diagnostic. So when the patient explain such a pain, such a neuropathic pain in this area, it is a pudendal neuralgia. It doesn't mean that it is an entrapment. It can be many, because there is many reasons of such pudendal neuralgia. One of the best known, well-known, and very important reason etiology is the entrapment, which is very important for us to detect, because it's one of the rare case where we can improve dramatically the patient and sometimes and very often cure the patient, which is quite rare in the world of chronic pain to be able to cure patients. So it's very important to detect that, and when it's when we make this selection of this patient, then surgery can be indication. And this is a recommendation of all the scientific societies to put the surgery in this position. Of course, there are the other option when the symptoms are not in the criteria of the entrapment, that what the well-known non-criteria, where the pain is aggravated by sitting position, never waking the patient at night, with no impairment sensation, no incontinence, and a good response with a block injection. Then you are in the criteria of entrapment. You see, we didn't find that the other exams than clinical criteria are more effective than today. The other examination, imaging like EMG, like MRI, are not so good as the criteria. That's why we use them. But when the pain is different, the pain is there all day long, even waking up at night. When the pain does not answer to the block injection, then there is other issue that can be due to other possibility when the patient has also overactive muscle, primary muscle, that can be related to this possibility. It can be due to neuropathic lesion after delivery, due to stretching, lesion of the nerve, after trauma, after some treatment, after diabetes, after chemotherapy, after herpes infection. So there are many other reasons to have a pudendal neuralgia, not due to entrapment.
Okay, thank you very much. That was very informative, a good comprehensive answer. So our next question is considering pudendal nerve blocks. So what do you recommend before indicating or recommending surgery? And how do you interpret a negative nerve block?
So one nerve, with a nerve block, we always speak about block tests, because it is included in the diagnostic approach of entrapment. So it's of course, when the nerve is the cause of the pain. Normally, if we put some local anesthetic, normally during the effect of the local anesthetic, you should have an improvement, and sometimes this improvement can be quite long, and sometimes you can have some therapeutic effect with some months of improvement, 6 months, and sometimes some complete release. So block nerve injection is most of the case diagnostic inputs, but it's also sometimes can be therapeutic. See, if the block nerve is working very well, we can repeat it. But if the block test is not only working, improving only one day or 48 hours, we are not going to redo the blocked nerve injection because it won't work more than that. So one is enough. I mean, if you have the criteria of pudendal nerve entrapment and a positive block test of 1 day, one block injection is enough before thinking to other option, because repeating the injection won't be interesting. But if the block nerve is working very well, then we can imagine that another one can work also for other months, but it's not very often. It's about the studies show that it's about 20% of the patient who have some very good response, like for a few months. And you asked me for what do you do when the blocked nerve response is negative? Then and sometimes some blocked nerve, some patient are coming back to us with an aggravating response, which is very important because it's helping us to make some other diagnostic, especially when the response is in aggravation. That is one of the symptoms of abnormal sensitization of the area. That means that this area is very sensitized, and then the pudendal neuralgia could be included in an abnormal process that we call central sensitization. So negative response and aggravating is most of the cases is included in a sensitization process.
Thank you for that information. The last question we have regarding diagnostics, do you have a medical article, a pamphlet, or a study that those of us with pudendal neuralgia can bring to their doctors to help the doctors understand better and for us to be taken more seriously?
Yeah, there is a lot of studies of work around many aspects of pudendal neuralgia, of diagnostic, treatments, surgery. But I will recommend a very important work which has been published in 2021, coming from the European Convergence PP Scientific Society dedicated to chronic fluid pain, and this is a recommendation for the management of pudendal neuralgia. You can find it out. I will send you, of course, you can find it in the literature in PubMed. It's quite easy because it's now open access. And it's very important because this is a recommendation coming from a Delphi method of all the experts of the world, giving the best way to manage a patient with a pudendal nerve entrapment, the first step, the block injection, what to do afterward, and you will see that surgery is coming quite quickly after after the first step of medical treatment, and before some other treatment like pulse radiofrequency, cryo, or Bautrant injections that we're going perhaps to speak about. So the name is recommendation in pudendal nerve entrapment, coming from the Scientific Society Convergence PP, and it's published on the European Journal of Pain in 2021.
Thank you. Very good resource. Yeah, I think Veronica is going to take over now for the next set of questions.
Veronica, you didn't open your microphone.
Yes. Here I go. So we're keeping this under 40 minutes. So we're going to take about 10 minutes for these questions or less. And so most of these questions comprise relating to pudendal neuralgia treatments along with surgery, which most of our members had the most common questions about. Primarily, why does Dr. Bautrant prefer the laparoscopy method rather than the transgluteal surgery method? And does he still use the transischiorectal fossa method of surgery?
Yes, I've tried all the methods actually. when I began in my exposure approach, and rapidly, I found that laparoscopic approach could be the best way to treat that the pudendal nerve entrapment. Why? Because when a patient has a long period of pain, even if there is no criteria of central sensitization, having a severe neuropathic pain creates some a reduction of pain threshold in the area. So it's when you put a scalpel in this area, you can have more reaction than in a usual patient. So I found very interesting not to cut directly in this area, in the muscle around, in the perineum, or so that's one of the main interests of laparoscopic approach, because you are putting all the instrument on the abdominal wall, which is usually not included in the pain process, and you because of the laparoscopy, it will help us to go very deep and down, and is today the laparoscopic approach is very developed, and we have many new devices. We have the 3D, we have the robot, so we are able laparoscopic to go very low in the pelvis. So sometimes it's not possible. So because the patient has previous surgeries, has been operated on for peritonitis, as a surgery, so it's impossible to reach the area of the pudendal nerve through the abdominal wall. So I still use the transischorectal approach, which is quite a good approach in women through the vagina and in men through the perineal area. But I think it's if I can, I prefer laparoscopic approach in order not to cut this area and to add some other pain in this area. And with laparoscopy today, we can reach all the areas who are involved in the entrapment of the pudendal nerve.
Wow, so you just answered one of our other most common questions: is can laparoscopy reach places and compressions that the transgluteal method surgery can? Because the common argument that some people have is that transgluteal provides the best view of the nerve and can reach places laparoscopy can't. But I'm glad that you confirmed that it can reach all places of compression.
I would like to add that transgluteal is a good method. Transgluteal is a good method. I think if the surgeon is very easy with approach, it's better to use that, because it's important to be to have an experience of a surgical experience, and try to another approach with no experience is not very good. So I think the transgluteal is a good approach. With my experience, I moved to laparoscopy, and I can reach many sites that the same sites that we reach with a transgluteal approach. And more than that, sometimes this approach helps us to reach some very high anatomical region, like the sacral roots, the sciatic nerve, and this surgery is very helpful sometimes when we have to go in this area to remove some nodules, some endometriosis, for example, which is another subject. But the laparoscopy, slowly with the years, we find that it's very helpful to go to many areas.
Wow. So not only the Alcock's canal and within the ligaments, but also in that other spot. I know there's a compression near the sciatic notch that you guys can reach. That is amazing. And so the next question we usually get is there risks for waiting to get surgery? And is there a limit, such as in years, of how many years you've suffered with it, or an age limit to getting the surgery as well?
No, there is never an emergency to operate, even if we have made the diagnostic of entrapment, even if we think that the entrapment is very tight. In many patients, the entrapment is there since a long time, and sometimes the symptoms the symptoms occur only after a few years, and it seems that the entrapment can be without any pain during years, especially after, for example, bad deliveries, which is creating some fibrosis, and sometimes the pain begins only 10 years, 20 years after the trauma, after the entrapment, and the nerve can work normally, being entrapped for a long time. And one day, after something. A simple thing. One day, a little surgery, biopsy, colonoscopy, something which does not touch the nerve, will increase the nociceptive input, the work of the nerve, and then the nerve enter in the pathology, and the pain begin. So very often we see patients who are coming to us and say, well, I was free of pain and I went to my gynecologist, he made a biopsy to my vulvar area, or during my colposcopy, or I went to the gastroenterologist to remove a polyp under colonoscopy, and then my pain came. So of course, for a patient, there is a relation on the surgery, on the after a long trip, or who could have been the reason. In fact, it's not the reason, because never a gastroenterologist can endure a nerve which is very difficult. You can, as we talked about, it's very difficult to reach a nerve surgically. So it's impossible for a gastroenterologist to hit the nerve during a colonoscopy. So the mechanism is different. The mechanism is a long period of entrapment, and then one day, when we increase the nociceptive inputs, then it will trigger the nerve and induce the neuralgia, and then the patient, unfortunately, begins to have pudendal neuralgia. So, knowing that, we can the conclusion is that we can we are not in an atmosphere or emergency. We have time to do quietly the surgery, and the other and it makes also the other answer to your question. We can have improvement of a nerve even after a decade of pain, as long as you can have a good improvement after a decade of entrapment, even if it's not painful entrapment.
Great, thanks. That answers a lot of questions. So it gives hope to patients who have been suffering with entrapment for years that they can still benefit from this surgery. And many patients, as this used to be called cyclist syndrome, get it from cycling. And then, of course, if patients are in severity of pain, they typically say it's better to get it sooner than later, especially if there's nerve damage.
It's always better to try to correct the pain anyway as soon as possible, of course. Right. But there is a real emergency.
Great, thank you so much. And the last question about treatments, and we can make this a quick one, is what are your thoughts on if people have had this surgery already and say it's been a year or two and they still haven't improved? If it's, say, a year out, would you recommend they wait that second year? And then if they have, do you recommend alternative treatments such as a repeat of the surgery, cryoablation, pulsed radio frequency ablation? And I know do you use Botox injections? I know that's a loaded question.
Yes. So after a surgery, you have two possibilities. The first one is, in the best case, an improvement, and everything is getting better, and you have after 2 years, 3 years, 5 years, a recurrence of pain and pudendal neuralgia. So this is a different situation than surgery and the pain is continuing, which is two. There are two situations. The first one, that means that the surgery and the liberation of the nerve was helpful, and the name of the pain, which is coming a few years afterwards, is a recurrence of the pain. In this case, if there is still same symptoms and also a good response to the blocked nerve injection, we can redo the surgery. Yes, it's possible. Yes, it's possible, and I think it's a good idea as long as the first one works to do another one. And so in this case, before better than using cryo or pulse frequency, we redo the surgery. In the other situation, when the surgery didn't work because the pain is still there, how long shall we wait before using other treatments? If we listen to the neurobiologists, they say that a nerve takes 18 months for complete regeneration. But actually, in a clinical practice, we should have an improvement after 4 to 6 months. So after 6 months, we should try something else. That is what we do here, in my opinion. Then, if there are two options, if it is still a pudendal neuralgia and still a good response, really a good response to blocked nerve injection, then we can use that to improve the patient. And then we use a little catheter. We put a little catheter along the nerve, connected to a programmable pump, and in the pump we can put regularly some local anesthetic, which is going all day long along the nerve, improving the pain and controlling the pain. It's sort of a continuing blocked nerve. So this is very efficient when we are in a situation of continuing pudendal neuralgia, with failure of surgery and still good response with the blocked nerve injection. If you have a failure of surgery with no response with the blocked nerve injection, then the pump is of no interest because the patient does not respond. I think that you understand that. So then we have we can have other option, and we can use cryo or pulse frequency, or you can use Botox, or you can use neurostimulation. In our practice, before neurostimulation, we can use cryo and pulse radiofrequency. The problem of this option is that they injure a little bit the nerve, and you can have some side effects. So you can have response, can have good effect, but you can have some side effects. With Botox injection is a recent validated indication, which is very interesting because we now know that Botox injection can have an other effect than muscle release, which is the usual effect of Botox. Botox has another effect that we know since a few years only. There is an axonal transportation and a neuropathic and the control of and Botox can control neuropathic pain. So we can, and it's also on sensitization mechanisms, peripheral and central, because of the Botox does not block only the receptor on the muscle of acetylcholine, but other receptor who are working on sensitization mechanism. So using Botox is interesting, and in patients who have, especially in patients who have many localization of neuropathic pain, we can use this injection. The protocol of Botox injection, the neuropathic protocol is quite simple. It's a little injection in all the area of the nerve, so it's not very aggressive, and it's a very interesting option.
Great. Thank you so much. So it sounds like in your practice, if someone is still experiencing pain after surgery around the 6-month mark, you prefer to first try the pain pumps before considering a repeat, correct?
Uh, if the surgery has been working, you can repeat surgery. If not, we use other options like cryo, thermocoagulation, Botox, and neurostimulation.
Makes sense. Thank you so much. So now we'll move on to our last group of questions and wrap this up here. So many people with pudendal neuralgia may have comorbidities, such as with provoked vulvodynia, vestibulodynia, bladder pain syndrome, myofascial syndrome, and SI joint instability or hip problems like a hip impingement, labral tear, or spinal issues from a bulging disc to tethered spinal cord. How do you handle a patient who has multiple things going on along with pudendal neuralgia?
All depend if these symptoms are included in the central sensitization process, or if they are coming from the in the evolution of the pudendal neuralgia. Because having a pudendal neuralgia during years, as I told you before, is creating with the time very severe inputs to the brain, and with the time you will have a reducing pain threshold and pelvic central sensitization. So all depend how began the situation. If everything began with the pudendal neuralgia, the first step was pudendal neuralgia, and then comes the vestibulodynia, the myofascial reaction, and all the symptoms or other comorbidities. We can imagine that treating the main reason, the first cause of the pain will be very important. But if all began with provoked vestibulodynia, dysmenorrhea, bladder pain syndrome, included with in such a syndrome, then pudendal neuralgia is only a neuropathic pain included in pelvic central sensitization. And then if we know that in that such situation, making the surgery is inducing some more pain and can aggravate the pain, even the neuralgia. So if we are in a situation in central sensitization, we should not operate it on this patient. We should treat the pelvic sensitization, and for that we use some criteria which called convergent pelvic criteria. There are others, but if we have this criteria, that means that we are in situation of a reduction of very low level of pain on pain threshold in the area of the pelvic pain, and we should not operate it on. In the other aspects, we can imagine that in treating the cause, we are going to reduce and to improve also the central sensitization. So sometimes we have to. The option is quite difficult, and the decision is sometimes difficult, but it's possible when you listen to the patient, we understand what's happened, to make the difference and to make the decision of making a surgery or not.
Fascinating. So it sounds like you have to determine whether or not the pudendal neuralgia is caused from pudendal nerve entrapment, and if that is caused, the central sensitization from being unaddressed and not operated on, or if their pudendal neuralgia is from another centralized process from a different issue. And so that's why consulting with you as a patient, you are an expert in central sensitization as well and can make that determination. And so another question we get is, why is there a disagreement between doctors who say pudendal neuralgia is central in origin and that it's a misfiring and a misinterpretation of the brain and they need a stimulator and don't need this surgery, versus doctors who believe that this surgery is beneficial for those who have central sensitization as a result of pudendal nerve entrapment. Can you explain more about that disagreement and that bias that certain physicians have? Because according to the research, for those that do have true pudendal nerve entrapment, I've read that pudendal nerve decompression surgery is the first thing that they should be doing. And then as a last resort, neuromodulation. But I know that with mainstream doctors who aren't aware of this surgery, because this is a rare condition, they tend to tell patients different things.
I think my colleagues who are thinking that all this neuropathic pain is due to central sensitization are right and also wrong. They are right because if you have pudendal neuralgia, you know that very well. It's a very severe pain. It's a neuropathic pain, and even with a local entrapment, this severe pain will induce a reduction of the central pain thresholds. That means that it's true. If regarding of this mechanism, finally, all patients with pudendal neuralgia have a degree have a degree of central sensitization. In other words, having a nerve pain for months, it's impossible not to have this response to the of the brain pain thresholds. So if we ask the question, are the patient with pudendal neuralgia, with pudendal entrapment in situation of central sensitization, we can answer yes, but it doesn't mean that we should not treat the cause of this severe nerve pain, and because we can think that then we are going to modify also the pain threshold, because there is a neuroplasticity. We can have the hope of modify and restore the pain thresholds by controlling the nerve pain. And they are right also because if the reason of the nerve, the pudendal neuropathy, the pudendal pain is the central sensitization, then, as I told you before, the central sensitization will induce some pain neuropathy, but we will have also some other nerve pain. You will have a curious sensation of neuropathic pain with on the leg, on the other area. So these the nerve pain induced by central sensitization are in most of the case very different. You can find in other places. So we can make the difference between central sensitization induced by entrapment and a nerve pain induced by a central sensitization.
Thank you so much. And we do have one last question. I don't know if we can ask it. Is that okay?
Yes.
Okay. Thank you so much, Dr. Bautrant. So our last question is a two-part question. Do you offer ketamine IV treatment for those who do have centralization? And do you use, and you kind of already answered this, do you use pelvic floor Botox for diagnostic purposes in terms of finding out whether or not their pudendal neuralgia is caused by muscle tension, pelvic floor hypertonicity, or entrapment? So I know that's kind of a loaded question. But
yes, it seems complicated, but it's quite simple. Even if we have symptoms of pudendal neuralgia and symptoms of entrapment, if these symptoms are associated with muscle overactivity of the perineal area, if these symptoms are associated with sign of sensitization, allodynia, vestibulodynia, or bladder pain syndrome, we should treat that before surgery. It's better to perform surgery in a situation, of course, it's not without pain, but with not in a situation of fire. So that's why before surgery, we treat, yes, the central sensitization. We work on myofascial release, and using ketamine is a good idea. Using Botox also is a good idea, because sometimes the muscle overcontraction is so important that physical therapists do not have resort, and Botox could be interesting in order to come to the surgery with some improvement with the muscle overcontraction. So yes, when we decide that we are going to perform the surgery for PNE, if there are symptoms of central sensitization, it's not a good news, of course. I would prefer to have some isolated symptom and sign of central sensitization association with myofascial overcontraction are not good prognosis, but it does not. It's not a contraindication, but it needs to prepare the patient before, and we need a multidisciplinary approach with physical therapists, with a psychological approach, with Botox, with ketamine, for example. Yes, before, if I think that the surgery will be indicated, then I begin with all these procedures.
Great. That sounds great. And so it sounds like for some patients, not all, but some, that their pelvic floor hypertonicity, their muscle tension, could mean that they still have pudendal nerve entrapment, and they could benefit from surgery still.
Yes. If you do not treat the reason, then you are going to treat all year long the muscle contraction without treating the cause. So at one point, you will have to try to release the nerve also, to liberate the nerve in order to control also the side effect due to the sensitization. Yes.
Well, thank you so much, Dr. Bautrant. You imparted a wealth of knowledge to us. And so we thank you so much for your time speaking with us today. It was such a pleasure to have you. So many people were excited to hear from you, and we are just thrilled that you gave us this special time.
Thank you, Veronica. Bye-bye.
Bye.